Hello, good afternoon. My name is Srikar R. Adhikari. I'm one of the faculty in the Emergency Medicine Department at the University of Arizona. We are going to get started. One of the speakers is missing. All right, hopefully she'll get back. All right. This is a ultrasound debate session. This is a recurring debate every year. This time we're going to talk about two topics, acute coronary syndrome and stroke. Tirado and myself, we're going to debate on the use of POCUS in the setting of acute coronary syndrome. Lori Stolz and Jason Nomura are going to follow us. They're going to discuss use of POCUS in the setting of stroke. We're going to get started here. Those are all my disclosures. They have nothing to do with any of the items I'm going to discuss in the next 10 minutes here. So if it comes to ACS, the use of POCUS in the ACS, I know a lot of you in the crowd, but I still have to say the point of using the ACS, it is focused on essentially looking at wall motion abnormalities and LV function. So that's what this discussion is going to be focused on. So essentially, as all of you know, the wall motion abnormalities you could see them within seconds after the ischemia sets in. That's even before you see EKG changes. So that's what makes point-of-care ultrasound a really attractive tool to assess patients with suspected ACS. So, if you look at, going back to the previous slide, if you look at traditional cardiology, we're looking at like 17 segments, and then there are a lot of simplified approaches described in our literature in emergency medicine side, looking at 3 segments, so which is very attractive when we can do these condensed protocols in the ED. So, a couple of studies are maybe, I think 3 or 4 studies have been published looking at the ability of our emergency physicians who can actually detect wall motion abnormalities. So here's one study which looked at, actually residents are the ones who actually with basic training performed point-of-care ultrasound in patients who had STEMI. There are about 75 subjects have been enrolled in this study. About 62%, I believe, had like a wall motion abnormalities in this study. And then when they actually compared it with the inpatient echocardiogram, the sensitivity and specificity are about close to like 90% for emergency physician performed study, the residents performed study. So there are a few other studies published similar to what I'm showing right now. Essentially, this highlights that we as emergency physicians with some basic training should be able to detect these wall motion abnormalities when patients present with suspected ACS to the emergency department. So with that, what I'm really not proposing here is, I'm not proposing to go perform a point-of-care echo in all patients who have STEMI. That's really not what I'm getting at. What I'm actually trying to say here is, we know a significant number, even up to 30% of the patients who actually have, eventually turn out to have ACS, have either non-diagnostic or even normal EKGs. And this is the group we're interested in, right? So the occult MI is what we're interested in. So what do I mean by that? So the occlusion MI comes in 2 different flavors, right? So one with the actual STEMI changes and one which is not, we don't see the STEMI changes. It's actually the second group which is we are interested in, because that's a group we can actually make a difference, where if you can detect that ischemia early on, then you can probably decrease the time to the revascularization. So that's the group we're interested in, and that's the group we want to perform our point-of-care echo and see if we can expedite management. So I will go through some scenarios here. Unfortunately, I have to talk it out because the SAEM would not let me update my slides. So hear me out what for the next few minutes, what these scenarios are. So I'll tell you the first one, which all of these scenarios are something you frequently see in the emergency department on a regular basis. Let's start with something with non-ST elevation ACS, something we normally see, right? So every day in the ED. So it has some criteria where it requires some ischemic changes, meaning in the EKG, like ST depressions or T wave inversions in the non-contiguous leads, and also elevation of troponin. And if you look at the most recent document, which is published by ACC and AHA, essentially gives at least 5 groups of patients who would need immediate invasive strategy. One is electrical instability, the ones who have like VTAC, VFib, and so on. And the second is the hemodynamic instability. And the third one is refractory angina. Those are all pretty clear cut. So we can recognize them and they can go to the cath lab. And the next 2 groups are the ones which are slightly difficult to tease out. One is the individuals who are at risk to have clinical events. And the next group is the initially stabilized high-risk patients. And this falls on us to pick up these 2 groups of patients. And if you look at the other criteria, including European Society of Cardiology, have this criteria, essentially says very high risk and high risk, also gives these more or less the same things to us. It's upon us to decide to risk stratify these patients so we can pick up the occlusio MI before we see those ST elevations in the EKG. That's where I think we really can make a difference using the point-of-care echo. So to start with, non-ST elevation ACS, there's actually something you can do with your point-of-care echo. Then we can go on to the next scenario, where it is your hyperacute T waves, right? You're always like trying to see, is this hyperacute, whatnot? And traditionally, classically, the description is when the ischemia sets in the first 30 minutes, you're going to see this hyperacute T waves, and then as the infarction sets in, you're going to see the ST elevations and Q waves and so on. But you are going to make a big difference in terms of before the necrosis sets in, if you can actually detect that using a point-of-care echo, and potentially you can convince somebody to take a cath lab. Again, this is a myocardium saving intervention, in my opinion. So again, the second scenario I'm describing is where you can go ahead and use your point-of-care echo when you're not certain you're seeing these hyperacute T waves. And the next scenario, which is commonly seen again, is a posterior MI. So when you have this posterior MI, they're not going to have classic EKG changes, ST elevations I meant. So you're going to have to look at the precordial leads in V1 through V4 and say, okay, who's having ST depression here? Do they have a tall R wave here? These are the things we're looking for. And notoriously, these are under-recognized. The most recent study which was published with more than 1,000 patients when they looked at it with the posterior MI, with the ones we have that have those precordial V1 through V4 EKG changes, about 25% of them had occluded arteries. And if you look at this population, it took about 29 hours after the EKG is done, they went to the revascularization procedures. So it really highlights that posterior MI is very under-recognized, and that, again, there's value in using point-of-care echo in that setting as well. And then comes the infamous AVR lead, right? So I don't know what your experience is when you talk to cardiology about any changes in the AVR. They act like they've never heard the word AVR. When I call them, they say, what AVR? I'm like, no, there's ST elevation in the AVR. And I'm like, I don't get the same, like when you activate the cath lab, they're very responsive. When they come to the AVR lead, it seems like they don't have the same connection. And I'm like, I know you're from India, you're a cardiology fellow, maybe I should speak in the same language, can I get you connected so you can get this going? So anyway, the few times the problem is when I get them to ED, again, one of the problems we encounter these patients that they're confused, maybe they have a situation, maybe they could have overdosed. Again, the dilemma is still there to take them to cath lab or not, when you have ST elevation in the AVR. So again, it has become it's very common in our hospital. So when you have things like that, we do the point-of-care echo. If they're convincing changes in the echo, they're more inclined to take them to the cath lab, especially with the AVR changes. And then the next one is the pacemaker. We have seen every one of you encounter the ST elevations in pacemaker. So when you see those changes in the pacemaker EKG, so again, you're like thinking, is this new, especially if you have a missing, no old EKG to compare. And again, this is also very useful in that setting to go ahead and perform that point-of-care echo. And then two other scenarios I want to describe is the ones which have the inferior lead changes. When you look at the inferior lead changes, we always want to think about the RV. Then we have to think about all these criteria. Is there disproportionate ST elevation in 3 more than 2? Is there a V1 elevation and also V2 ST depression? By the time I think about all about this on myself, I'm having a stroke. So at this point, you're better off go ahead. But it's very important, right? You have to recognize if there's RV infarct or not because the management is quite different. So again, I think it's a great use of point-of-care echo in this setting as well. One other thing with the inferior lead changes is, we have heard these stories and you have seen the medical legally is the aortic dissection. Again, you want to go back and you want to look at those aortic dissection either in the parasternal long axis view or in the or even in the suprasternal view. So tons of things out there where the EKG changes could be transient or it could be they're ambiguous in settings like this. So really, I think it's extremely useful in these settings. And in fact, in our shop, we have collected probably close to like 50 patients right now. These scenarios where we're not quite sure what exactly is going on with this EKG, we performed ultrasound and we called the cardiology and we were able to actually convince cardiology to take him to the cath lab. And then about 80% of the patients who went to the cath lab where we detected regional wall motion abnormalities had corresponding acute coronary obstructive lesions. So I think we do have some good data on these ambiguous cases or equivocal cases. Patients presenting not straightforward STEMI, but still were concerned. We went through all of that stuff. So again, we're traditionally taught time is myocardium, right? So, and can POCUS really make a difference in early diagnosis or PCI and improve outcomes? This is what it comes down to, okay? I see Megan Hurst in the audience, and I'm going to show her one of her studies she published. So this is a retrospective study where emergency physicians performed point-of-care echo. STEMI patients were excluded here. They include about 234 subjects. And they looked at how soon after this patient came to the emergency department they had a troponin resulted, and also how soon it took for them to get a point-of-care echo, and how soon it took them to get to the cath lab. Was there any difference in patients who went to the cath lab if they had regional wall motion abnormalities versus they didn't? So the data is from this study suggesting that people, the patients who have regional wall motion abnormalities ended up in the cath lab much earlier. That its time period is much shorter when it comes to the ones who didn't, and obviously it's. The point-of-care echo was performed, I believe it's like more than 30 minutes, like shorter compared to troponin. So there is some early data here suggesting that we could make a difference in terms of going to cath lab and potentially that could change the management. So in summary, what I'm proposing is we don't need to scan every STEMI patient who walks in, but there are going to be situations where the EKGs have subtle EKG findings or a lot of ambiguous situations where I think point-of-care echo would help you risk stratify those patients and help you to call the cardiology and maybe even convincing some of those patients to go to cath lab. And maybe by doing so, you may shorten that time period. You can go to cath lab and potentially save the myocardium. With that, I'm going to stop there and don't believe a word Al says. So he's going to follow me. So. Got it?
Yeah, got it. Oops. Shoot. Okay, here we go. Well, thank you so much for being here today, and thank you so much for Srikar to have me here today. Now, obviously, this is actually called Controversies in Emergency Ultrasound, the debate raised on. And everybody that knows me knows that I love Star Wars, so I have done it for the last 5 years. Why not today? So this is my interpretation of our debate today, okay? You can be in the right side or you can be in the wrong side, but there's definitely a side, right? So I definitely don't have any disclosures. I just wish I did. Now, I will say that today, I'm glad that I don't have any disclosures because I was able to update my slides, okay? I got you there, brother. Anyway, so what we're trying to do today is actually, can ultrasound help us diagnose early and make changes in outcomes, right? So I wanted to start with some of the cases that my peer here actually started today. So it's about 1915, EMS calls you, they said that there's a 65-year-old coming to emergency department, 5 minutes, chest pain, and this is what you get. Okay, who here has a problem with this EKG? If you do, probably you should go back to residency. No, but just joking aside. This, you get it, and what's your next step? What are you gonna do? Probably you're gonna just call your friendly interventional cardiologist, it's early at night, right? And what they're gonna tell you? That's a clear-cut case, right? They're gonna take it to the cath lab, and guess what? The patient fixed, period, right? Now, what Srikar was trying to say specifically, and by the way, this actually was a true case. It was taken from the moment that the patient came in to the cath lab was about 20 minutes, okay? This is what we should do every day. Now, does this happen every time? Of course not, right? Let's see the scenario number 2. Now, this is a 57, also, kind of young person, chest pain. Now, the patient's coming with describing that he is having pain on his arm, 8 out of 10, with diaphoresis. Now, by the way, I'm not AMAMA 2, but I will tell you, this is a patient that really concerns me, right? This is a patient I want to see what's going to happen. Now, I do an EKG on this patient, the patient's still having chest pain, and this is my EKG. Now, can I truly say that this patient has an MI? Well, there's stuff there that is concerning. Probably if you look at that V2, there's some reciprocal changes there. But it's not a clear cut like the other one, right? Still, the AHA and ACC guidelines tell you that this is a patient that you're still going to call them. Now, obviously, there's other things you have to use, right? You're going to be using your EKG. You're going to use your now high-sensitive troponins, right? And you're going to still do your HPI. And guess what? This patient also goes to PCI. Did I have to do an ultrasound for this? Well, if you work in a busy ER like I do, you have no choice, right? You want to do what is best for the patient, and you want to take this patient quickly to a cath lab, right? So the real question is, can POCUS help us differentiate ACA patients in need PCI, right? And there are really a lot of factors that they're going to affect if you really can see anything on that echo, right? Number one is to be able to see wall motion abnormalities, you have to have at least 90% of stenosis of the arteries. And obviously, that's not going to happen all the time. So you might still do an echo, and the echo might be normal, right? The other thing is, it's going to depend on the area that is being affected, how long has it been going, and of course, the degree of collateral circulation. So if the patient has a bunch of collateral, guess what? You might not be able to see anything in the echo either, right? Now, the sensitivity of echo is going to also decrease depending on the size of the area involved. So if it's a small size, you're not going to be able to see a lot, right? And of course, we do know that AHA states that this is a class 1 recommendation, do echoes, right? Fine. Now, I will show you a small study, right? And this is more about trying to identify how we can actually use ultrasound, right? But I have a couple problems with this, right? Number one is just 2 cases of describing how we can do an approach that is more condensed, right? So the other thing that I have problems with this is that people doing this are ultrasound fellows, ultrasound fellowship trained people. Guys, I cannot get my residents to even do a regular gallbladder ultrasound sometimes, right? Imagine yourself asking for a STEMI, right? Or a heart attack, okay? Now in this little description, they actually use 10 minutes as the time for checking wall motion artifact, and they basically show them a couple of videos with that. And then what they try to do by AHA is that you're supposed to have 17 areas they're going to be scanning. they actually simplify that to just a couple areas, right? And these are views. You have your long parasternal, short axis, apical four-chamber view. Now, I'm going to introduce you guys to a couple of terms here. Hypokinesis, dyskinesis, akinesis. Everybody knows this in this room, right? So I don't have to describe that, what they are. Do we? I can guarantee you, I can show everybody here an ultrasound, and everyone's going to have a different idea of what the hell it is. Now, with that AHA guidelines, you're supposed to give a number, and that's going to help you decide if the severity of contractility is going to be affected, right? Going from a 1 that is normal versus 15 that is actually super high, right? So that's not going to be very helpful for us, right? So in this little area, they basically kind of describe the areas. I just put this just to have a visual with it. And the idea is, if you want to see here, this basically is kind of anterior, lateral, kind of posterior, and septum. They divide that in even shorter, right? They basically talk about the anterolateral, anterior, anteroseptal segment. That's kind of the red line there. The yellow is supposed to be the base on the inferior segments. The blue is supposed to be anterolateral and the inferolateral segments. And that actually correlates with an affected artery, right? Now, in this small case series, what they described was that they were able to see problems and they identified it early, right? Now, if I show everybody right here, this is an example. So what do we have here? Anybody wants to guess? Is this akinesia, hypokinesia, dyskinesia? God bless me, help me God, I don't know what the hell it is. Well, there is something. There's a wall motion abnormality somewhere around here, if you guys are looking at. And when the motion is actually going outward, where it's supposed to be, right? When you're contracted, you're supposed to be going in this case, going outward, that's supposed to be dyskinesia. And I'm glad that actually somebody wrote it there, because I would have probably had problems with that, right? So how good is ultrasound to detect regional wall abnormalities? And I guess, I have to thank Srikar, because he kind of introduced some of these things. But yeah, this was a prospective study for people with chest pain. They actually used 3 emergency physicians with 3 hours of education, and then they have experienced cardiologists actually reviewing their ultrasounds, right? So they have an N of 292, but they excluded a bunch of people. People had STEMIs, people had tachybradycardia, CHF. So that dropped their numbers to 181. And then about 22 of those had no consent, or the images were poor. How many of you have issues getting images for the apical four-chamber? Raise your hand, please. I'm not the only one, right? Specifically with body habitus, right? So out of those 89, right, what they found was the sensitivity and specificity for that was 76.9%, with a confidence interval that it was actually kind of about 95%, and specificity about 92. So I guess that's not bad, right? But again, it took a bunch of time to be able to get that there. Another study that I know Srikar also brought in. Now, what he's telling you is that, yes, they use residents, right? They use 9 residents. All of them have 25 ultrasounds for echoes already done, and a minimum of 150 ultrasounds. So can a first year on their first week, by the way, what happens in July 1st? I'm dreading that. I'm sorry, I'm being recorded, but that's fine. I love my residents, okay? But it's gonna be a perfect storm. You do have novice people are gonna be doing ultrasounds. And the reality here is that with just 2 video instructionals, they said that it was about 295 patients. Out of those, they excluded the majority. They ended up with 75 patients with a STEMI that they were enrolled. By the way, there was no 75 because they actually lost a couple more, so 69 were the final. And they did find that about 62% had motion wall abnormalities, right? With a sensitivity about 88% and specificity about 92. But again, these are people that already had an MI, and they're doing this afterwards. So if this was so important, why didn't they do it before? I'm just saying, right? Okay, another study here, just to go with Srikar. This is actually point-of-care ultrasound may expedite diagnosis of occult occlusive myocardial infarction. I know he talked briefly about it. This was actually a pretty good study. They actually did it for 38 months. They did exclude a bunch of people, and they did it on purpose because people that had STEMIs, you don't really want to exclude the data, hypotension, already patients that had dysfunction with the LV. They actually had the same thing. Their EKG, standard ultrasound, everything else. They had 1,561 patients, but guess what? Exclusion criteria was 874. So that was not really, it was a lot. And then after that, 453 patients were discharged. They never went for intervention. And guess what? From those 434, only 23 patients had coronary interventions, and out of those, 11 had wall motion abnormalities. So you're telling me this retrospective cohort study is telling me that the majority didn't get revascularization early anyway? So I do think that there is probably a good way to go with this. Now, where I see that there's some opportunity is maybe with speckle, right? And speckle tracking is going to help you to, it's semi-automated. It will go with those AHA guidelines, 17 segments, and it will give you a better idea of what's going on with the heart, but I still don't think that we're there. The other option probably would be AI. Now, AI is exciting, right? I know that for those of you that have ChatGPT, you know, you're very happy with that. There's a lot of things that you can actually do with that. But the reality is here is basically where you may have some opportunity, but it's not going to be at the naked eye of us trying to do this because a lot of people are going to miss. Now, this study, they have about 4,100 patients, about 2,800 examinations outside of the hospital. And guess what? The accuracy was about 96%. So I personally think that even after we have done all of this, I think that we don't have enough data. You cannot change my practice right now. I'm not going to stop seeing 2 or 3 more patients I might have in aortic dissection for a patient that has no EKG changes, has negative troponins, and then I'm still thinking they might have something because I'm looking for it. Yeah, I'm going to find it if I want to, but I don't think the data is right there right now to be able to do so. The other thing is, I'll be honest, with novice providers, I think that there's going to be a learning curve, and it's going to take them more time. So I personally think that there's more research needed. And any questions? That's where I'm going to leave it. So thank you, Srikar. I love you too.
All right, so hi, I'm Jason Nomura from Christiana Care in Delaware, and as you may have heard, both in our session and other sessions, there's some limitations on when we can update our slides, so yeah, I don't have a lot of slides because I missed the deadline. However, we'll try something a little different. Since we're all sort of young and technologically advanced, since we're into ultrasound, if you go to my Twitter profile, pinned at the top, there may be a video of additional images that would correlate with my talk. They're not my slides per se because I could not update them before the CME talk. But if you were to pull up that video, it might scroll through some images that would help, that might look like slides via like Wizard of Oz, Dark Side of the Moon kind of thing. All right. So just to start off, I do have some disclosures, none of which will influence this talk, but that's sort of why we are in the position we're in. So with those disclosures, I'll kind of go over some different things, and I'm talking about the pro stance on using ultrasound in stroke. So one of the things is you can talk about carotid ultrasound, right? I can image the carotids, spectral Doppler the carotids, get beautiful images and assess for stenosis or blockage. But that's really risk stratification and looking at inpatient treatment or outpatient follow-up, right? Doesn't really affect me in the ED. The other option is I can do transcranial Doppler looking for vasospasm in the subarachnoid hemorrhage patients, right? But once again, I can get the baseline images and the baseline velocities to look for that vasospasm 48 to 72 hours after. Doesn't really affect me in the ED. These both are very important for stroke, but not really important for the acute management in the ED. This sort of falls into that we can do it too kind of thing, right? Where the inpatient team can do it, they have resources to do it, I can do it too. Doesn't really help me move patients through my department, doesn't really help me affect their acute care. The area that does help And something that does help our acute patients is mechanical thrombectomy, right? That's the acute intervention. If we have a large vessel occlusion, mechanical thrombectomy based on multiple trials tells me that I can affect that vessel, I can get that clot out and get reperfusion and improve their outcomes and improve their disability and do a lot of good things for them. The problem with large vessel occlusion and mechanical thrombectomy is you have to have a large vessel occlusion, right? So you have to get that angiogram, you have to get that vascular imaging to know that, one, there is a blockage and that there is something to go after. And I can CTA all these patients and I can find the blockages and I can get them out to their intervention. But what if they actually have a true contrast allergy, like anaphylaxis? What if I'm in a rural hospital where I don't have the ability to do the angiogram? What if I'm somewhere where my CT scanner just went down for either maintenance or something broke, or my trauma patient bled all over the ring and it shut down, which has happened. And now I can't get the angiogram. Do I just transfer all of these acute stroke patients out? Do I send them all to the thrombectomy center? Do I intubate all my potentially allergic patients and just angiogram them anyway? Or do I send all these patients up to the cath lab to get an angiogram every single time for a digital subtraction angiography? Neither of these are great options, right? And when we look at who can get mechanical thrombectomy, if we look at the recent data that's looked at availability to patient populations, less than 50% of your population is going to have access to mechanical thrombectomy, partially from the country they live in and the availability at the hospital, but also geographically, right? We have a very large country with large areas of rural hospitals where patients don't have timely access to mechanical thrombectomy just because of geography and logistics. And that's the same in many developed countries in the world. And if you move internationally, it rapidly drops off based on country income. So then, right, I'm going to do my non-contrasted CT, and I'm going to rely on the hyperdense MCA sign, right? I'll see that hyperdense MCA, I'll see the clot. Those are patients I'm going to send out. That's only about 20 to 30% of your MCA thromboses that will have a hyperdense MCA sign, right? And that's if they've thrombosed the MCA. If they have a small emboli that's blocking off somewhere, that's not going to give you a hyperdense MCA sign necessarily. If we then take those images and we reconstruct them to 0.5 millimeter or 0.6 millimeter slices, I can do these hyper thin cuts through it. And if I have a neuroradiologist, they'll pick up a few more hyperdense signs, right? That improve their findings in one study with three neuroradiologists and a very small sample. So not great. So is there a solution for me to get the vessel imaging without being able to angiogram them? Yeah, that's why we're here, right? Transcranial Doppler. I can image the vessel, I can see flow in the vessel, I can assess the spectral flow through that vessel, and I can look for an occlusion. I can look for the problem, and then I can send those patients out for mechanical thrombectomy and interventions if they need to, right? And if you look at the old studies with ASLID, the original studies where they did imaging, it's through the transcranial imaging through a temporal window, right in front of the tragus, right? The little divot right there, right? Transorbital through the eyeball to get to the carotid siphon and the ophthalmic artery. My temporal will get me my MCA, ACA, PCA. And then transforaminal, you flex their head and you image through the foramen magnum, and I can see the vertebrals and the basilar. And if you track it up far enough, you can get the posterior communicating artery either off the basilar or off of the PCA. So you can get the entire circle of Willis. You can image for those obstructive lesions, right? First, I'm going to get that grayscale image with my phased array. If you may have noticed, there's an ophthalmic setting on your phased array. That's not for ocular, that's for transorbital TCD. I can find the brainstem, and then I can start looking for my vessels, right? With power Doppler on, I can map out my vessels, so I can put the little spectral gate on there and look at the flow. I don't have to memorize the angle, the direction, and the depth that I have to insonate on the old non-imaging Doppler systems. Right? It's become much easier for us to get these images. And I can look at the MCA, and I can look at the flow through there. And I can grade it on the Ticky scale, right? Do I have normal flow? Do I have stenotic flow? Do I have absent, dampened, or blunted flow? And so I know where the occlusion is. And on those slides, you may notice an image where you can actually occlude the carotid, and you see in real time that that waveform just drops off suddenly. You can also then image through the foramen magnum, and you can see the vertebral coming up to the basilar, and you can spectral that vessel too. And so you can interrogate all these vessels and find those occlusions. So now I know who needs to go for mechanical thrombectomy. But is it realistic? In the US, we haven't been doing it. You know, there's that big controversy that it was in our milestones to graduate as a resident and nobody was really doing it. It was an aspirational goal, but it is being done in some places. Like in many things with ultrasound, a little more developed in Europe. So if you look at some of the studies, in the SITS trial where they looked at patients going for thrombolysis, so intravenous thrombolysis, over 9 years, about 2,500 patients got TCD either pre or during thrombolytics. So that's a fairly large number, right? And that's only the patients who got treatment. The ones who didn't get thrombolytics also received TCD. So they're using it much more commonly across the pond. A little less so here for us because we have CT angiogram, but it is possible. The other thing that you may not notice, like how many people have mobile stroke units at their institution? Yeah, wonderful, right? We don't have money. But the initial precursor to the mobile stroke unit was that the vascular neurologist who did TCD went into the field to meet the patient. And doing TCD in the field also allowed them to find those large vessel occlusions and reroute those patients towards mechanical thrombectomy centers. And they had pretty high specificity, right? Sensitivity was in the 70s, specificity was in the mid-90s, so it worked. Now, with CT, we have a few more options, so that's why that sort of became the mobile stroke unit default rather than TCD. And then when you start looking at the studies, TCD and angiograms correlate pretty well, both for occlusion, presence of occlusion, location of occlusion, and sort of where in the vessel the occlusion is. So it does work pretty well. When you look at studies and you start pulling data, there's less and less data about the correlation and effect of TCD to diagnose it because they started moving into TCD for monitoring these occlusions and looking at sonothrombolysis as a possible therapeutic, which didn't pan out, but it was sort of there as just a default diagnostic study, just like angiogram, to find these occlusions. And then if you look, you can image, and some of my samples on those not the slides, but on that video, you may notice that it's been transcranial Doppler without imaging, so it's just the regular M-mode TCD that we used to use to show like occlusions, recanalizations, and things like that. And I'll be honest, I could do it, but for our patients, we can rapidly get a CT angiogram, and if I don't need TCD, I don't want to then hop in with TCD and delay some of the therapeutic options, right? Because sometimes I can get them to the neurointerventional suite in under 40 minutes. But for the patients that I can't do angiogram, this is a viable option, and we have used it on occasion and time to time. So I would say you should consider TCD not as your primary imaging modality for large vessel occlusion, but that should be your option and something to practice and get good at for when you do need it. And depending on where you practice, you may need it more often than you think. All right. Wait, where's yours? Oh, there we go. There's yours. There's yours.
How do I make it? Oh, it's just play it. Okay. Hi, everybody. I'm Lori Stolz. I am the ultrasound director at the University of Cincinnati. And thank you so much, Jason. You are a worthy opponent. So I'm in an interesting position today because I am taking the con position for using ultrasound, which is usually I'm all pro ultrasound. And so this can be a little bit difficult, but I like using ultrasound for a few key reasons. I like being efficient. I like making patient care better. And I like to be able to do something that I can't accomplish with other tools that are available to me. And when it comes to using TCD or ultrasound in the setting of stroke, it doesn't meet that bar yet. And so for this, it's a no-brainer. Do you get how I did that? Yes. So, and I'll talk through that. So I have no disclosures, thank God. We could use ultrasound for stroke. But should we? That's the key question that we're going to talk about today. And so I would say, it's not the key and critical action that needs to be taken. It is a poor alternative to the existing strategies that we have. When we take a step back and we look at acute ischemic stroke or any patient who has stroke-like symptoms that comes into the emergency department, this is peak emergency medicine, right? It is time limited, it is acute, everything is moving quickly. And I got 99 things to do, and ultrasound ain't one. We gotta get an NIH, we gotta get a glucose, we gotta get an IV, we gotta get that patient to CT scanner. We are bypassing even going to a room if we can, so that we can get the patient what they need ASAP. And why? Because stroke is incredibly deadly and incredibly debilitating. luckily we have options. You know, there's lots of diseases that we treat that are deadly and debilitating, and there ain't much we can do once we diagnose this. But with stroke, there really is, and it's very, very time limited. So for every 1 minute saved, for every 1 minute sooner that you can get somebody that needs thrombolytics, you are saving 1.8 days of healthy life. And that's for all stroke patients seen, including the ones that need TPA. For every 1,000 patients that come in with a stroke, if you are able to give your thrombolytics even 15 minutes earlier, you're going to have 15 people less that die. You're going to have 17 fewer patients that end up needing assistive devices in order to ambulate. And you're going to have 22 more that can care for themselves at home. That's huge, and that's only 15 minutes. And we're talking about an exam that takes about 15 minutes to do. So when we're talking about doing ultrasound versus not doing ultrasound in this situation, we really want to focus on the patient and the outcomes for the patient. And the time is what we need, not the ultrasound. Now, when it comes to researching stroke and how to make our job as emergency physicians better, how to do this better, how to provide for patients better, so much money has been spent on stroke. So the red line is how much money has been spent on stroke over the last 15 years versus the green line spent on all of the rest of emergency care once it's parsed out. And with all of this research, we've discovered lots of things that make us better at caring for stroke patients. We have taught EMS how to better recognize stroke in the pre-hospital setting. We've taught family and friends how to better recognize stroke in the pre-hospital setting. We've had mobile stroke units come about, which have CT scanners on them. And we've encouraged patients to go straight to CT. We've found that having an ED pharmacist available gets thrombolytics faster. We've discovered better thrombolytics, TPA versus TNK, and mechanical thrombectomy. Now, of all this research that's been done, the millions of dollars and thousands of papers, let's go over the ones that have shown a benefit to patients in the setting of stroke using ultrasound. Yes, there are none. There haven't been any that have shown that it benefits the patients. All of the studies that are on this topic are still at the level of feasibility. And the better studies that have been done are applicable to NSICU patients, the ICU admitted patient that's being monitored. You know, I talked to literally anybody that I could get an ear with prior to this talk to be like, okay, like, how could we use it? Like, think big here. And they were like, there's some ways, but I just don't see it happening right now. And some of them looked at me like I had three heads. And so they all pointed me back to the stroke guidelines, and it has 75 pages, 500 references, and using ultrasound in the acute setting for stroke is not listed in there. But I like to think big. I like to be open-minded. Maybe there's a role for ultrasound, and there have been some studies published that look at feasibility, like Jason said, looking at carotid stenosis, looking at LVO, and looking at even intracranial hemorrhage. And so for carotid stenosis, there was one good study done that looked at POCUS done in the emergency department, and then they compared this with CTA, and they're looking for greater than 50% stenosis to diagnose carotid stenosis, because these patients do better when they have carotid endarterectomy done early. But they only found low to moderate association, so most of these patients are already getting the CTA. It doesn't add much. Also, we've kind of learned that a standard ED performed study that's just looking at stenosis is probably not going to tell the full story about the patients that are most likely to benefit. The findings on ultrasound of neovascularization, of the plaque morphology and ulceration, those are probably actually more helpful in identifying patients that need to have early endarterectomy anyway. And then we talk about LVO. In a resource-limited setting, this may be all you've got to work with. But all of these other imaging modalities actually get you better information than the ultrasound does to make the same diagnosis. When we compare ultrasound to just the physical exam, so overall, the area under the curve, so like the balance between the sensitivity and the specificity, that's how I think of area under the curve. When you're looking at an NIH, it's about 0.9 to diagnose an LVO. When you're looking at ultrasound to diagnose an LVO, it's about 0.91. So just learning our physical exam skills could actually do a better job for us in identifying these LVO patients. In ICH, there's been several studies done. The role for this is really in monitoring patients that clinically deteriorate and when CT isn't available. And this is used in our ICU because packing up a patient to get them down to the CT scanner from an ICU, that's a different story than from the emergency department. And you know, I'm trying to be very open-minded, and patients who have contrast allergies, this could be applicable. Patients who are concerned about contrast-associated AKIs, formerly known as contrast nephropathy, again, a possible opportunity, and patients that don't have other imaging. You know, if everybody in our country could have access to high-level stroke care, then there wouldn't be any role for ultrasound. But that's absolutely not the case. You know, we have worked for a long time to make a full network, but all those dark red spots are areas where particularly underserved populations, Native Americans, low income, where they don't have access to a primary stroke care center. But as much as I want ultrasound to work, these are the nails in the coffin of using ultrasound for stroke. It takes too much time. That time can be used to care for the patients with stroke. Windows, 20% of patients have no windows, and that proportion goes up in older patients, precisely the patients that were going to be imaging. Training, the AHA recommends that you get the European Neurosynology certification in order to be able to do this, which is a test and a hands-on section, and only 20% of people pass it. So it's challenge accepted, but it's probably not something I'm going to be doing anytime soon. And then accuracy. It's just not as accurate as other options that we have available to us. If we really cared about stroke patients and on a population level, if we as emergency physicians want to make stroke care better, we would be a lot more willing to talk about tobacco cessation. We'd be a lot more happy about the Swallow study getting done and talking about blood pressure medications. For every 10 patients that have a stroke, 4 of them could have been saved if they had had their blood pressure adequately controlled. We'd be talking about statins in the ED. So for this one, I'm gonna have to side with the donut of truth. CTA is the test that they need. That's the test that they're gonna be able to get in my department. MRI, MRA, likely very equivalent. And for what we need in the moment, we need to see the full picture, not these little shades of gray. And beyond that, you know, in life, I identify first as a mom and a wife, then as an emergency physician, and then as an ultrasound specialist. And so when I'm making that calculus, I prioritize those things. And in this situation, I gotta be an emergency physician first. We don't wanna be that person that when you're a hammer, everything is a nail. And so rather than being a hammer, we can be the whole tool belt, and we're gonna set down our ultrasound machine for this one. Thanks.
We're right on time. Any questions or comments?
I believe Jason himself also is not believing what he presented actually. So 100% he can actually test with that. But what we learned, we want to just make sure I'm referring to the work that Dr. Adhikari did actually, looking for the number needed to treat. So I give you 3 examples. Cardiac arrest, patient with the STEMI, and the patient with stroke. So first one, every single one, its number is 1. So the outcome, not the outcome of the patient, but the changes happen based on ultrasound we do for cardiac arrest. We still have 20 years to get that to the AHA. Okay. Just think about later on for the STEMI. STEMI, how much we are benefiting. Maybe a little better than actually like the less than actually cardiac arrest, but we can help. So it's important in your mind to decide what not to do. What not to do is that for stroke, I did a study and I started doing actually for one of my fellows was super excited about this. Something called a brain attack for any stroke that is coming. We decided let's do the carotid and just do cardiac. I never felt idiot more than the time that I was doing the scan. And aborted at 60 cases. Because impossible, because it's just worthless, because you're just making fun of yourself. At the time that patient is born that far. So that's my comment and real feeling by doing actually at the time of the patient had the one. I'm not talking, but if you use this one, the way they tell all the like transcranial for pediatric, for stroke, never been successful ultrasound outcome based more than that for all the cases with the sickle cell based on the ultrasound they got for the TCD. TCD for the patient with the sickle cell disease has been life-saving. It's been how many patients with stroke actually like we prevented. Look for that. The right patient, right diagnosis, right assumption. That's getting you the wrong way.
Thank you. Any other comments, Megan?
Only, I agree with everything Tom just said. I want to just add the only time that ultrasound has helped, I agree with everything Lori said as well. Sorry. I'm sorry. But the only time that ultrasound was super, super helpful in strokes was dissections. Because dissections can be missed when you do the whole algorithm for stroke, even though they can present as stroke. And unfortunately, patients can get TBA, which can be the end of their life. It's a mortality mistake if the dissection is missed. That was all I wanted to say.
Any other comments? Thank you. Thanks for coming to session.